we're going to have a really interesting debate, and then we'll have a chance to have some conversation afterwards on an important topic, which touches both on the disease in question and the way we use device therapies. Jeff Healey, I think, will go first. He's professor of medicine at McMaster University. He's at Hamilton Health Sciences Center. And I think all of you know Jeff pretty well. He's a world expert in both devices and the treatment of cardiac arrhythmias. Erkan Ilhan is in Calgary, where he's been since 2014. And he's been practicing electrophysiology in Calgary most of the time as an invasive electrophysiologist in the EP lab, operating room, and he does clinical arrhythmia care with a special interest in inherited arrhythmia disorders. And they'll give us different perspectives. I think, as might be expected, there will be no fisticuffs, but there will be a vigorous debate, which unfortunately is not easy these days in the world stage. And then we'll have lots of chance for discussion. I think Sean will introduce the case, if I'm correct.
Yeah. Thanks, Paul. Sean Connors. One of the other arrhythmia specialists here from out east. In fact, you can't get much further east without getting wet. Steve and I flew up from Newfoundland out of the fog bank and got in last night. This is a really important topic for us, Steve and I, because the care of these patients with this particular genetic mutation that we're going to talk about this morning has been my life's work, right, for the last 25 years since I left Ontario to go back and work in Newfoundland. And I landed kind of at ground zero for this mutation. When I came over from Europe, it seemed to touch base in the rock, and it stayed in the rock. And of course, it's all over the world, and you guys have all seen patients with this. I'm going to tell a very quick anecdote before we get started, because it underlines the importance of, we don't really know, and that's why we're having a debate here, what to do with these people. So a very well-recognized site in California had an electrophysiologist that contacted Hugh Calkins, and you guys know about Hugh, in Baltimore with questions about this TMM mutation. And the question was, we've got a dad down here, he's got an ICD and he has this mutation. He's got a daughter, she's 36 years old, and she's admitted to hospital because she got struck by a motor vehicle. So she's admitted, she got a fracture, she's otherwise well, but we noticed on the monitor she's having a ton of PVCs. And so he said, Hugh, what do I do with this? And he said, look, I don't know. Why don't you contact Sean and Kathy Hodgkinson in Newfoundland? So I got an email that night and from California, and it painted the picture. And he said, look, they're having a ton of ventricular ectopy. They're completely asymptomatic. She's a woman. We know about the dad. We put an ICD in there. I've seen your work. What do we do with these people? So we emailed back our thoughts, and I'm sure thoughts that we're going to get reviewed here. And 2 hours later, after I sent the email, I come back to email, oh my God, tragic. She was found dead on the ward here in the hospital. And it just, for me, it was like, this is an unbelievable thing that has happened. So I think getting the information out about this patient, the cohort, the implications, and what we know. We don't know everything right now, but maybe we should have this information more widespread than what it is. So I'm really glad to participate, or at least help moderate this debate. So I have, I'm going to outline the case. Maybe we could just pop up the slide of the case, and I'll just read it, and then we'll set.
Brianna, are you working on it?
Yeah.
You can probably just.
Yeah. So what's that, Jason? I'll just go through. Yeah. So the case we're gonna put and allow our two distinguished speakers to debate is a 31-year-old lady with the TMM, S358L variant, the one that we're very familiar with in Newfoundland, completely asymptomatic, carrier status identified through cascade screening. Her mother carried the variant and had an ICD inserted at age 42, and she had an appropriate shock at age 45. This lady in our case participates in sports, but not really intense sports, kind of typical of what people might normally do to stay in shape, otherwise healthy, on no medications, ECG is normal, echo and MR are normal, 72-hour Holter shows a low PVC burden, runs of non-sustained VT. And then the question is, assuming you believe an ICD is indicated, what type of ICD is recommended? And I would say there's probably two parts to this debate. Do you really think an ICD is indicated? And then if you do, what type of device? Because it's not uniformly accepted, I would think, by everybody. So I'll stop there and hand it over to our first speaker.
Yeah, and I think the debate will be more subcu versus transcu. And during the panel, we'll discuss about when.
All right, so thanks, Sean. And like Jason said, I think we can get my slides back up and we'll focus on the ICD. But there's the ECG, looks pretty unimpressive.
Yeah, there's a run. I think we showed a run on. Yeah, absolutely. And Dr. Green, I'm sure will comment on this, but she had a run of V8 after, but this is not sustained when she had right after.
Okay, so maybe while we're loading up my slides, I'll just preface this for people in the room that we're going to take a debating format, some rhetoric. We're going to make some extreme comments to win points off each other. So don't be dismayed that we do, there are both are reasonable options here. So there's no wrong answer, but I'm going to argue that the subcutaneous device is the better answer and take the pro side on this. So there are my disclosures. And what am I going to argue? I'm going to argue three things. In general, in life, in engineering, in logic, simple is always better than complex. And I think with this in mind, we should not overestimate the value of unproven therapy. I talked a lot about Stuart's earlier work in device trials. We had a lot of things we thought were just wonderful that ultimately proved not to be very helpful. First, do no harm. It's a thing that doctors say when we graduate. I think we have to talk about the upfront morbidity of ICD therapy, and particularly the perioperative complications in the short term, but also things like lead survivability and damage to the tricuspid valve over the long term. And then finally, a very McMaster thing, evidence-based medicine. What do the trials show? How do they help guide therapy? So first and foremost, when we look at an ICD system, these are triumphs of engineering. They're really marvelous how they progressed over the last 25 years. But if you wanted to pick the one weak link in the system, it's the transvenous lead. And you can see here some data for one particular type of lead that we haven't implanted for more than 15 years. But you can see there by 6 years, the very high failure rates approaching 25–30% within 6 years. And so these things are designed to be small. We like that. But of course, the flip side is sometimes there can be reliability issues, and these are just blank numbers on a chart. When you go and take out a lead that's broken like this, or where you have externalized cables like that, this can be a very dramatic day in the extraction room to manage such a complication, and sometimes they're even a little more frightening when you pull them out. So it is a weak link. It can break. Fortunately, most of the time it doesn't, but it is, the rest of the system is so highly reliable that this stands out. And so how do you deal with that? So first and foremost, those are overall results I show to the failure rates of leads. This is a really nice study looking at younger people, the average age in their 40s, who got ICD therapy. And here, after follow-up, we're not talking about fraction of 1% per year failure rates. Look at this: lead malfunction 10%, lead dislodgement 3.5%. They're really, these are about 3 times higher rates of late lead failure in the younger cohort, average age of 39, compared to the overall population. Why? People are more active, they do more things, bigger muscles, more stress, and of course, the leads live in there for a longer time. So that's the issue with chronic leads. So, what do you get for a lead? What's the cost? Because of course, with the S-ICD, that's a clean sheet solution where there is no lead inside the chest. So, when you have that lead no longer under the ribs and moving with the lungs and moving with the heart, it's just sitting under the skin, between the skin and the bones. So it's a much lower stress environment. Plus, unlike that lead that I showed you coming apart with multiple cables twisted and insulated from each other, this is a single conductor, and it's very, very robust. You pull on a standard ICD lead, transvenous lead, it'll come apart. You can water ski behind a subcutaneous lead. There's a video online you can see of this just to demonstrate its tensile strength. So, it's going to look better, but what's the cost, right? So The argument, which is no doubt going to come, and probably from Sean Connors too, is you need ATP, you need anti-tachy pacing, because that's the best way to treat VT. I think, one of Stuart's peers would be Art Moss, who did the MADIT series of trials. And this was a shocking result for the trial. They did 3 arms, regular programming of the device, and then 2 types of programming that made shocks less likely. They either delayed therapy or they set a very high rate for intervention. And you can see here, in terms of their primary outcome, significantly improved probability of inappropriate therapy, which was expected, I guess. But if you look at the tables down here, what wasn't expected is in both of the arms where intervention was delayed or put off, there was actually a reduction in mortality of about 50%. And you could say, well, it's not pre-specified, it's just play of chance, but to hit it in 2 different arms at the same time, that's a heck of a shot, right? Because you can see it's significant in the one and 0.06 in the other. And what's most interesting about this is it wasn't, we had this idea that shocks were harmful, shocks killed people, and unnecessary shocks were best avoided. Shocks were exactly the same in both these arms. What was avoided was anti-tachy pacing. So there's no difference between any of these arms in the rate of shocks, appropriate or otherwise, but what's different is ATP is less. So, do we know that it's, this is suspicious, but is it compelling? I think it definitely should grab our notice and ask the question, why do we deliver ATP? What's the goal? Well, the goal is obviously to avoid painful shocks, and both the MADIT RIT trial as well as this recently presented APPRAISE trial show that you do indeed do that. That makes sense because many of these arrhythmias will terminate with ATP. But again, shock, 50% reduction in death. So take your pick. What about if the patient, in Sean's case, develops monomorphic VT? These are just the various industry solutions to that. We have modular devices where we can put in totally implantable device inside the heart that communicates with the subcutaneous ICD. The Medtronic solution is with a device that goes into the mediastinum. And of course, we can use all number of ablation catheters to ablate the tachyarrhythmias in patients that develop maybe not so much TMEM43, but other types of diseases. The final counterpoint for my opponent is, what about inappropriate shocks? And I would just draw people's attention to the fact that this is a new technology. When I was Marty's fellow running around, inappropriate shocks with a transvenous device, we're about 15% of people got an inappropriate shock each year. That has plummeted. You can see on the right, you can see the very low rates of inappropriate shock, and the rates are starting to come down a lot with subcutaneous ICDs as well. Proper screening for T waves has gotten better. Different filtering of how we measure that has gotten better, and avoiding the ever-present the TENS units and Dr. Ho's foot massager. So if you take nothing out of this lecture, don't let your patients with ICDs get a Dr. Ho, because they will get an inappropriate shock for sure. And I'm not sure their feet are going to feel much better, but that's just my opinion. Randomized trials, what do they show? We're now switching gears to safety. This is the Praetorian. There's 2 large randomized trials now in the last part of this, comparing S-ICD to transvenous device. Both are tipped looking at safety. So the early safety, as you would expect, when you're not putting anything into the chest, into the heart, you're going to have a lower rate of complications, including lead-specific complications. In our Atlas trial that we ran here in Canada, the same sort of thing. You prevent about 92% of all the implant-related complications, things that typically are only associated with going into the chest. So, collapsed lung, pneumothorax, hemothorax, perforated the heart, and such complications. You can virtually eliminate them because you're avoiding the context of being inside the chest cavity with your lead. What's interesting is all this thinking now about tricuspid regurgitation. So leaking of the tricuspid valve, you're putting a lead through the valve into the right ventricle. What is the long-term impact? It's hard to know, right? Because people that get ICDs often have sick hearts. People with sick hearts often have dilated right ventricles, and the tricuspid valve looks looks unhealthy in these individuals. These are observational data, a good starting point, but a large number of patients, about 8,000 patients, and about just shy of 10% had worsening tricuspid insufficiency after they got their transvenous device. That's first point. The second point is if they did, their mortality went up about 1.6-fold. So this is concerning. And we did look at this in Atlas. It's probably the only randomized trial that will ever be done looking at the effect of a transvenous ICD on the tricuspid function. And the answer to the trial is the number 7. So approximately 7% of people develop moderate to severe tricuspid insufficiency within 6 months of having a transvenous device. And this is 7 times greater than what we see with a subcutaneous device. So we definitely do cause some tricuspid insufficiency. There's evolution in thinking of how we cross the valve and how we deliver the leads that's going to be taking place over the next little while. But this does happen in a significant minority of individuals. And I think that's probably the only study that will actually randomize people. Maybe if anyone's doing new ICD studies in patients, that would be another good thing to look at. So simple is always better. So my motto is if you can convince me that a more complicated solution is better, I have open ears. But until then, my starting position is go for the simplest procedure. In terms of harm reduction, I think in the short term, there's no doubt that the subcutaneous ICD is safer to put in. Probably in the medium term, less damage to the tricuspid valve. And we wait to see, but the survivability so far of the subcutaneous lead is orders of magnitude better than transvenous leads over long-term follow-up. Evidence base is modest, right? We have 2 trials, less than 2,000 patients total, or fewer than 2,000 patients total. But we have both of those trials in long-term follow-up to see things like inappropriate shocks, appropriate shock efficacy. So with that, I'll pass to my colleague for the opposite opinion. So thank you.
Okay, can I have my slides, please? Okay, thanks for selection committee for this opportunity. And I am extra happy to have Dr. Healey here because I realized that I wouldn't convince him to vote for TV or conventional ICD. So it's better for him to be here than there because one less vote for me, for sure. I can guarantee. Okay, so whatever the data Dr. Healey showed is not coming from ARVC population. They are coming from different nation. They are like an non-arrhythmogenic cardiomyopathy people. They are coming from ischemic cardiomyopathy or other sort of cardiomyopathies. I will try to show you the relevant data on this particular patient population. So regarding this TMAM43 mutation, we know it is very malignant in terms of arrhythmias, and we know it is fatal in male, for example. It is well established. I have 5 or 6 cases in Calgary. They are all women. They are all coming from Newfoundland, and they all have ICD, but they seem to be doing well. So with respect to what is going on in females, this study is the best one to give some idea. So what happened there, they just observed 68 female with TMAM43 mutation or variant, and another 68 women with the same families, from the same families. And they just observed them for about 8 years to see what happened to those female. And whoever had poor precordial RV progression or enlargement of RV or LV, low EF, prolonged QRS, or PVC more than 1,000 got ICD. Only 10% or so did not have any of those, but they were given ICD. And they matched this cohort with another 68 affected female, meaning like they have either variants or they have cardiac event or they have obligatory carrier status. So the follow-up showed after 8 to 10 years, there's mortality benefit, 3.6 relative risk ratio in the woman with ICD. And interestingly, 75% of the shock was actually for VT, faster than 240 beats per minute, which can be a surrogate for sudden cardiac death. But the limitations of this, they could not determine the drug effect, such as beta blockers. There is no data. We know we can do MRI nowadays to see if there is a fibrosis. This may help for risk stratification and the decision. And also, we know that now exercise as PKP2 related ARVC may be a factor for arrhythmia for that patient population as well. Those are all new data coming over a few years. So the question is there an indication for ICD for this woman? If yes, conventional or sub-Q? So when I see this woman, it looks like 31-year-old individual at risk of ARVC rather than having a clear diagnosis of ARVC. So relevant data, this is very new, and thanks to Johns Hopkins group, sub-Q versus transvenous defibrillator in ARVC population, relevant to this topic. So the cohort given ICD between 2011 to 2021, and they gave 57 sub-Q ICDs to people with ARVC. They all qualified task force criteria, and they matched that group with 88 people with conventional ICD, and they followed this cohort to see what happened. So their conclusion is inappropriate shock is far more common in sub-Q ICD, which is not a big surprise to anybody, not to me. And of course, procedure-related complications higher in conventional ICD because we have the lead there, but composite outcome is not different, but quality of life measure way worse for sub-Q ICD group. So let's have a look at closer. This is typical ARVC population, high risk. They have 32% of VT ablation, 78% proband, 43% is percent of male, 37% had syncope. And when you look at the cohorts, actually, it is not well balanced. Transvenous ICD group is looking more advanced disease, such as T-wave inversion is 3.6 as opposed to 2.9, and non-sustained VT is in majority of the cases in conventional ICD, but not much in sub-Q ICD, and conventional ICD group is older. So they said appropriate ICD shock are same. This was a big surprise to me because I was hoping or expecting to see more ICD shocks in the conventional group because they have more disease, advanced disease. And I took this opportunity to test our ARVC risk calculator to see what will be the expected VT and what is observed, because this is a typical patient population for this calculator. They have mostly PKP2 variant. They have task force criteria match. All of them had task force criteria met. So this is the result of this. So expected actually arrhythmia is 46% in conventional ICD and 24% in sub-Q ICD. What is observed, 42% and 35%. So of course, ATP will lower the shock rate in transvenous group. This explains this drop, but it is impossible to explain why more people having shock in S-ICD group. And as we all know, when we see a patient with cardiomyopathy and ICD shock, when we look at the EGMs clearly, sometimes they are torsade. And even RCTs are failing to discriminate which patient having cardiomyopathy-related polymorphic VT or VF, or it is simply torsade. So those people have risk for torsade, yes, of course, because as you see, this is a high-risk group, arrhythmogenic cardiomyopathy, not ischemic cardiomyopathy, not HCM. Those are arrhythmogenic cardiomyopathy. Almost 40% is on QT prolongers, and we know pacing may help to lower torsade possibility, and I wonder were some shocks in S-ICD group was due to lack of pacing, lower rate pacing, irregularity, short, long, short, and torsade. So when we look at ATP success, it was very successful in ARVC group. 34% saved at least one ICD shock thanks to ATP, and 9% of the cases did not have any shock thanks to ATP. And this is a feature of conventional ICD, not sub-Q ICD. So ATP prevents ICD shocks. those patient population will need bradycardia pacing sooner or later. Why? Because we give tons of antiarrhythmics to these people. They have very high burden of arrhythmias. And even to start with, in that cohort, 60% of people had actually dual chamber devices. So we need bradycardia pacing for these individuals. Inappropriate shocks, 23% in S-ICD group, 10% in conventional ICD, most of them for T-wave oversensing for sub-Q, only like most of them for atrial arrhythmia for conventional ICD. The difference is you can fix atrial arrhythmias with ablation medications. It is not easy to fix this T-wave oversensing with sub-Q ICDs. And more importantly, inappropriate shocks did not differ significantly by S-ICD based on whether smart pass filter was on or off. 57% of this cohort in that sub-Q ICD had the opportunity of smart pass filter, which is supposed to lower the inappropriate shock rate, but it did not in ARVC group. Maybe it is doing in ischemic cardiomyopathy, but not in this group. So body image, range of motion concerns worse in sub-Q ICD group. Even after 1 year, people were changing their clothes. They found themselves more, less attractive because of sub-Q ICD, and it is statistically significant. So now, 2 studies Dr. Healey showed, Dorian and Atlas, they are not for ARVC cases for the right side, they are only for other type of cardiomyopathies. And the composite endpoint of inappropriate shock or device complications were not different, and they found non-inferiority for sub-Q ICD. But when you look at appropriate shocks, it was more common in S-ICD group. And again, it might be because of ATP success in that patient population. But when you look at the breakdown of the shocks, you will see more VF, numerically more VF in sub-Q ICD. I wonder if it is from Torsade or not. But the bottom line, pay attention there. Ventricular tachycardia below therapy zone. S-ICD gave 11 shock. How come? It was oversensing. So when device gave an oversensing triggered shock, they looked at the rhythm. If it was like a VT under detection oversensing, they classified this as an appropriate shock. To me, it is not that appropriate. It should be in the inappropriate section. And if you actually add this to this, probably they would not have met non-inferiority criteria for inappropriate shocks or whatever the composite endpoint of there. So not lots of, but some patients required CRT upgrade. Regarding Atlas, of course, elite complications were higher, but there was more a trend for inappropriate shock in the sub-Q ICD group. And when you look at the cohort again, ARVC is just 4%. And when you look at the death, interestingly, 3 deaths over 6 months in sub-Q ICD group. There is no detail that I could find, but one of them happened in the surgery or after the surgery, and they thought to be lidocaine toxicity and more myocardial infarction in sub-Q ICD group. So with that, we'll go back to ARVC population. Another very good data with Dr. Healey's contribution. What we do about these cases with ARVC compared to North America and Europe, relevant data. So in North America, we put 3.1 more fold higher ICD on those people. It is valid for low risk group for ARVC risk criteria or calculator. It is also true for intermediate risk, also high risk. So we put way more ICD than Europeans in North America, 3 times more. And the bottom line is the lower rates of ICD implantation in Europeans did not translate to apparent harm. So closure. So our case, we need to discuss whether ICD is needed or not. Shared decision making, of course. I think she had an option to have close follow-up with MRI, rhythm monitoring, lifestyle changes, less exercise, more beta blocker. But of course, it's this shared decision making. Anticipation of a future regret by a physician, meaning my patient will have an event and that will be the sudden cardiac death. So this should not let you to go an ICD decision, particularly a simpler approach for sub-Q ICD. It is not simple. It is not an innocent therapy at all. So I think if the decision is ICD, it should be conventional ICD. Why? ARVC is naturally progressing, more fibrosis, more ventricular arrhythmia, more anti-arrhythmic medications, more sinus node dysfunction, more AV node problems from medications or by itself, more risk of torsade. You need this low rate of pacing in some patients. So we need to give conventional ICD to prevent torsade with over-the-right pacing, to have the opportunity of ATP, pacing for bradycardia, for upgrade for CRT or left bundle, but no S-ICD. Why? Inappropriate shocks due to oversensing. VTs under treatment cut off. Like if you have a patient with VT 190 beats per minute, but they set it to 200 to lower inappropriate shock rate, what's going to happen to that patient? Like there is not even a monitor zone to monitor those people. Screening process, another resource utilization. You need to do a treadmill test. You need general anesthesia or other types of specific anesthesia. You need DFT. It is not without any risk. And in Atlas trial, about 4% of the people failed DFT in the procedure. Battery life is shorter, more surgeries, and bigger device, more body image concerns. S-ICD for some people. Last slide. Last slide, okay. S-ICD can be used for anybody who does not need really any pacing and you don't anticipate any pacing, such as channelopathies, sudden cardiac arrest survivor with VF, but no cardiomyopathy. Thank you so much.
Outstanding, I don't know. It's technological. Thank you. Okay. Thank you very much to both of you. Excellent acceleration at the end. I'm going to take the liberty of asking both our speakers and the panel 2 questions, if I may, and then Dr. Connors will have comments and we'll open it up for questions or comments from the group. In terms of the decision to implant an ICD, it's quite clear that this patient has a pretty high risk with long run of what looks like monomorphic ventricular tachycardia, which is longer than just a couple of beats. So it's obviously important. But imagine this patient had no specific risk factors apart from the gene positive status. How does one figure out, given that the patient likely will need an ICD at some time in the future, but she's pretty young? So imagine she had a Holter with essentially no ectopy, very little fibrosis on her MRI. Would one wait, or would one want to implant at this particular age nevertheless? Or how does one follow these patients if one's not going to recommend an implant right at this time?
Okay, thank you. For this case, there is no fibrosis in MRI, completely normal. Like there is no noticeable detectable cardiomyopathy in this case. VT, yes, monomorphic, relatively slow, and responsive to beta blocker. In the slides, it does not mention, but the patient had shorter, slower VT with beta blocker. So ICD is a reasonable option for this case, but of course we need to incorporate their thinking process and values. If they are okay to follow, I can partner with them and I can, follow them closely, ILR, MRI. But if they think reasonable for ICD, then I would go with conventional ICD. I have 5 or 6 cases in Calgary. My experience is less compared to others, of course, but they seem to be doing well with conventional ICD. They don't have like significant TR or something like that, so they are doing just fine.
So again, in the spirit of debate, I'd say slightly different. If, obviously a shared decision making is important. There are many factors, personal history, family history that will dictate one person's decision relative to another's. The long-term issue is a factor here. How many leads, transvenous leads, will this person need over the course of their lifetime? Because they don't have much else wrong with them in terms of health issues. You might expect them to live a long time. And when you start cluttering up the venous system, you can run the risk of occlusion that precludes you from doing a CRT or easily anyway in the future. and you can get by. And also, you know, many of these patients will go and be followed and not have any therapies, right? So in fact, the majority of patients in the next year after you put a defibrillator in such a patient will not have any therapies. And the following year, the majority will not have any therapies. And you're covering off your bases. But maybe pass it down to Sean for the specific, sex-specific, mutation-specific commentary.
Everyone thinks this is a really rare mutation, and as you said, Erkan, in Alberta, they're all related to people from Newfoundland. Paul used to tell me when he made this diagnosis, the next question was, where you from in Newfoundland? And he was almost invariably right. But this mutation, like based on the calculation for the associated haplotype, occurred in 700 AD in Europe as an autosomal dominant condition. This is pervasive everywhere. We're just not looking for it, I think, in lots of places. And maybe as evidenced by that I started with that anecdote from California. I just like, for the people that implant ICDs here, who would implant an ICD or who would not implant an ICD in that case? Like, I don't know if there's 100% right or wrong answer. I'll tell you our experience, but would people follow this patient with an ILR or?
I'm guided by your data. So the CircuitP paper, I feel you know more than anyone else.
Well,
and the CircuitP paper says females over 30. Males are different. But I have been doing that. Females over 30, but I find a lot don't have episodes. Like you famously say, unlike all of the other genetic subtypes of ARVC, ACM, the decision is based on just age and the genotype. You don't look at phenotype. And I think that holds for males because it's so aggressive. But females, we have nowhere near your numbers, but an appreciable number of females that are 50, 60, that we put devices in that have not had events. And looking at the data in the CircuitP paper, part of the rationale was the youngest person to die suddenly was around mid-30s. And in other areas of cardiology, that wouldn't be a justification to say, okay, well, we'll put ICDs in everyone a few years younger. So I was talking about this on Sunday. What do you do now for females? Because you were like, the paper, it's age cut off 30 on the paper. So what do you do now?
Yeah. No, Jason, we wrote, because of the two deaths that we had at age 37 and 43, which we didn't feel that they had any symptoms, we kind of adjusted at the time. And we were putting ICDs if they had a mutation after the age of 30. But in reality, if you look at that paper, and Erkan actually showed the slide, almost all of these people had some evidence of penetrance, whether it be the Holter monitor was abnormal, echocardiogram, could be signal average ECG, and it could have been ECG showing poor airway progression. So they almost all had one of those things. So we've evolved a little bit over the last decade, and what we've done is that we follow all these people with a mutation every single year in our inherited heart clinic. And we do all those tests to look for any evidence of penetrance. And when we see one error or one feature of penetrance, we have the ICD discussion. If they're athletes, that often happens in their 20s, and if they're kind of normal levels of activity, it'll often occur in their later 30s, early 40s. The median age of implant in this paper for females from our group was age 42, right? And the interesting thing is, if we talk about what happened after we put it in, you say year after year after year, they're normal. But in 5 years, 20% had evidence of a defibrillator that needed, or evidence of arrhythmia that needed intervention. And after 10 years, it was around almost half the people, 50%. So these is not 1 or 2 or 3% that you're intervening on. They have the disease and the burden of disease. And the average natural lifespan without any therapy at all is 67. Sorry, the median age of death is age 67. So it's shortened. So I don't know what you think, Steve, but Steve is one of the other arrhythmia specialists that works in our group and is fully immersed in this population. But we have kind of nuanced our approach. It's not just for males, absolutely. It's a genotype approach. And in women, it's a combination of genotype, but we need some evidence of the phenotype. So that's how we go about it.
And this is enough to say you can't hold.
Absolutely.
Yeah, so we recently looked at a lot of long-term, like the past little while, I've been looking at a lot of the long-term data over the past 20 years. So since Sean's started looking at these patients. And basically, if they don't have a phenotype at all, they seem to be very low risk, and a lot of them don't get a defibrillator. So it's like, as soon as they get a phenotype, like we said with ECG changes and that kind of thing.
So what is the phenotype? What on ECG is a phenotype like? Or
A lot, loss of the R wave in V3
That's
to
enough,
less.
right?
Yeah, I think like that. We just look at like hundreds of ECGs over the past 25 years. And one of the earliest finding in most patients is the R wave in V3 drops below 3 millimeters. That's like the earliest finding. And
It's
then
not lead placement?
it's not lead placement. No, I mean, occasionally look on a couple of patients, it happens transiently and ignored those, but looking over the long term, if the R wave drops in V3, that's usually a sign that the ECG is going to change. So as soon as they have a phenotype on ECG, lots of PVCs, which Sean is talking about.
Yeah, we
1,000.
okay. Just to move on a little bit, a quick question is how closely correlated is the loss of R wave to morphology changes on the MRI?
That's a good question. We don't have a lot of MRI data. Like when they were originally put in cascade screen, we had lower
Right.
access to MRI.
Okay.
So
So I have one question for the two debaters, which I think is relevant to the transvenous versus sub-Q ICD argument. Do you think that that long run of non-sustained VT is the same clinical arrhythmia that the patient is destined to have if they're going to have an event? In which case, one might imagine that ATP might be useful. Is that predictive, or is this just phenotype positive and the patient's going to get a shock for VF or extremely rapid VT, not pace responsive?
Yeah, I don't think that's going to be the arrhythmia that kills them. I think it's a marker, and it might be an arrhythmia that draws in unnecessary ATP, right? And you think you've done a great thing because the ATP's delivered, but if you look at the published data, we're talking about VTs 220, 230, 240 beats per minute is often what's documented. I would just make one quick point about the discussion. Great discussion around the observational studies. Why is there more shock than predicted by the risk score? Because you're not looking at a population of patients with ARVC. You're looking at a population of patients with ARVC whom a very experienced, thoughtful center elected to give an ICD. They're higher risk for reasons that are not measured in the risk score. So I'd just say two things. We have a rare disease. We don't often know what to do. So we need to network and build bigger networks to get more data. We have these management questions. We don't know what to do. We need to do more trials to sort that out. That's the only way you're going to get to the bottom.
Yeah, regarding your question, this VT is slow. It can be a marker if it is coming from scar tissue. It may be just idiopathic too, but it can be thought as a marker. But sub-Q ICD will not even see that VT because their lower cutoff is 170, I think, or some of them will be seen, and the patient can stay in that rhythm. If they have this for days without any notification, they may have other complications. But yes, ATP in ARVC group can be helpful. Yeah, this is my final comment about this.
The question I'd have, yeah, just to wrap up, or maybe we can just have a quick thought on, is ascertainment bias. We see these people and we consider ICDs, but we only see the people that are alive and that can come into clinic. We don't, if they have 14 different brothers and sisters, like we don't know what happened to them. Typically, like the person that arrives in front of you might not have the same type of arrhythmia burden as the true risk in the family, if you know what I mean. And so do you think that that influences this type of debate? Because I'll just throw out a number to you. When we put genotype specific therapy at age 18, ICDs in males, 90% of first therapy is for VF. And when we find secondary prevention people, they show up to us late and it's clear that they have the disease, we put an ICD in, only 30% of people show up with VF and the rest is VT. So presumably those people died, right, and didn't get to us. So there's a big dynamic shift in the arrhythmia burden and the type of arrhythmia that you need to have treated, and perhaps do you think you need to think about that when you first design your therapy for that arrhythmia?
Yeah, I think it's a good point. If you think this VT is associated or because of the cardiomyopathy they have, you may think the patient declared herself as a relatively slower and monomorphic VT. As you said, like when you put primary prophylaxis ICD for patients without any arrhythmia, and they may actually have the benefit of sudden cardiac death. So this can be a point during the discussion with the patient, I think. And again, that patient was responsive to beta blocker. After Holter done after beta blocker, it was not showing that much fast or sustained VT at all.
I think we have
Okay, yeah. Thank you very much. I think in the interest of time, we want to thank the debaters and thank Dr. Connors for his expertise, and we'll move on to the next session. Thank you.